Hi everyone. In this video, we'll be discussing an exciting topic that is antinergic drugs. So, antinergic drugs is also called as the sympathetic drugs, and we know that sympathetic system gets activated when the body is in the flight or fight mode, and also it is activated when there is anxiety. Imagine that when you see a snake, what your body reacts is sympathetic system. So, in this video, we'll be discussing what are the drugs which are useful as sympathetic drugs, and what are their indications, adverse effect, all those concepts. So before I begin adrenergic drugs, it is also called as sympathetic drugs. Sympathetic drugs. Now let us recap. What does sympathetic system do? So when we activate sympathetic system in the body, what happens? I told you it is responsible for the fight, then the flight and fright response. It is also responsible for inducing anxiety. So sympathetic means fight, flight and fright, which is an emergency situation. So sympathetic is for emergency situation. Then in the heart, it has known to increase heart rate, conduction and force of contraction. We have discussed that. Yes. Then in the lungs, it has shown to cause bronchodilation. In the eye, yes, can you take a guess? What does it do in the eye, sympathetic system? You are correct. It causes mydriasis and we call it as active mydriasis. Now what happens in the bowel and bladder? In bowel and bladder, it decreases the motility. So what happens? There is decrease in evacuation. That means patient will have constipation. When you decrease evacuation, obviously there is constipation, because in emergency we don't want the urine to come out, we don't want the stool to come out. Then penile, so it is responsible for ejaculation. So these are the important highlights what the sympathetic can do: the flight, fright and anxiety, heart, lung, eye, bowel, bladder and pills. So that is our introduction. Now once we introduce this, let us understand the neurotransmission. We understood the neurotransmission in parasympathetic system. Let us understand the neurotransmission here. Neurotransmission in sympathetic system. So you know that this is a nerve. We call it as presynaptic terminal, and one more nerve. This is the postsynaptic terminal. So we should have a neurotransmitter, and the neurotransmitter released at the junction of sympathetic fiber, and the name is called noradrenaline. It is called as noradrenaline. Is there any other name for noradrenaline? Yes, it is also called as norepinephrine. So the major neurotransmitter in the sympathetic system is noradrenaline. And what is the receptor on which it acts on? There are two receptors. One is the alpha receptor and one more is beta receptor. Sir, okay sir, in every places noradrenaline is a neurotransmitter, but there are exceptions. What are the exceptions? I have told you that in introduction of ANS. Exception is in the renal and splanchnic, or what we call it as mesenteric blood vessels. In renal and mesenteric blood vessel, the neurotransmitter is dopamine. It is dopamine. One more exception is in adrenal medulla. What is adrenal medulla? It's a modified ganglia. Obviously, what is the neurotransmitter there? It is the acetylcholine. One more exception is there are certain glands called thermoregulatory. Which glands? Come on, sweat glands. So in these, even though they are sympathetic in origin, but the neurotransmitter here is acetylcholine, and acetylcholine obviously acts on muscarinic receptor. So the neurotransmitter in the renal and mesenteric blood vessel is dopamine, and it mainly acts on the receptor D1. So these are the exception: renal and mesenteric blood vessels, adrenal medulla, and thermoregulatory sweat glands. So we understood in brief. It's a recap for you. Now, what are the receptors in sympathetic system? The receptors in sympathetic system are like this. The receptors are alpha 1, alpha 2, then we have beta 1, beta 2, and beta 3, and dopamine receptors are D1 and D2. These are under sympathetic system. We'll come to that later. So you know the neurotransmitter is mainly noradrenaline, you know the exception, you know the receptors now. Now once you know this, let us understand the neurotransmission, what happens actually. Neurotransmission in sympathetic system. Neurotransmission. So what happens here? Let us understand that. Let me write the presynaptic terminal. So this is the nerve. Just writing bigger so that we can accommodate more information here. So this is the presynaptic terminal, and this is the postsynaptic terminal. So I have written it in a bigger manner. That's it. Now, the neurotransmitter has to be synthesized. What is the starting material? The starting material is phenylalanine. From that, what we get is tyrosine. So I'll start from tyrosine. So from tyrosine, we get a substance called dopa. It is called as dopa, and the enzyme responsible for that is called as hydroxylase. So tyrosine hydroxylase is the enzyme which will convert tyrosine into dopa, and from dopa we get dopamine. And the conversion is done by dopa decarboxylase. Now once this dopa is there, it has to be shifted into the vesicle. So let me write the vesicle for you. So this is the vesicle. Let me write a bigger vesicle here. This is the vesicle. So for this, the dopamine is put inside, and that is done by a transporter called vesicular monoamino transporter 2. So VMAT2, vesicular monoamine transporter 2. So it will transport the dopamine into the vesicle. Now once the dopamine enters inside, it is converted into noradrenaline, and the enzyme is called as hydroxylase. So it is called as beta hydroxylase, or you simply remember as hydroxylase. So most of the places you can see it is hydroxylase, and one place it is decarboxylase. So this is the synthesis of noradrenaline. So tyrosine becomes dopa, dopa becomes dopamine, and dopamine enters inside with the help of VMAT2, and that will dopamine will get converted to noradrenaline with the help of hydroxylase. This is your biochemistry. Now what happens whenever there is entry of sodium, there is entry of calcium also, the positive ion. So this will tell the vesicle to fuse with presynaptic membrane and release the neurotransmitter noradrenaline. So noradrenaline is released here. When the noradrenaline is released, it acts on the receptors alpha and beta. These are the receptors. Now when the noradrenaline is released, it has to act on the receptor, and after acting on the receptor, it should not stay there for a very long period, because it's a neurotransmitter. It has to come and deliver the message and go. You compare that with the ANS, that is parasympathetic system, the neurotransmitter was acetylcholine. How it was terminated? The action was terminated mainly by enzyme cholinesterase. But here, the action of noradrenaline is terminated by the uptake, and the uptake is done by a transporter called noradrenaline transport, and the process is called the uptake. So this is the uptake process. Now once the noradrenaline enters inside, it is again put back into the vesicle by vesicular monoamino transporter. So noradrenaline which has entered inside is again stored into the vesicle with the help of VMAT2. Now if this noradrenaline which has been put into the presynaptic membrane can be metabolized by an enzyme called MAO. So MAO stands for monoamino oxidase this can metabolize norelin and depletes its level. So MAO can deplete noradrenaline level. Okay, clear. Now sometimes what happens, noradrenaline can leak out of the synapse, and when it comes outside, noradrenaline is metabolized by one more enzyme, and that is by COMT. So COMT doesn't play so much of role in metabolizing noradrenaline when it is released in synapse. But same drug, when you give adrenaline, noradrenaline through the vein, if you are giving it with the vein, let me write here. So this is the blood vessel, and we gave noradrenaline. Then when we give noradrenaline through the blood vessel, there are enzymes called COMT, so that will metabolize noradrenaline faster. So there are also MAO. So who will metabolize this faster? When you give it in the periphery, it is mainly the COMT enzyme. But in the synapse, the story is different. In the synapse, majority of the noradrenaline action is terminated by uptake, and the major enzyme to metabolize is MAO, and the minor enzyme is COMT. But in other tissues, it is mainly COMT. So you got the points here. You understood the neurotransmission. Let me repeat again. Tyrosine will give rise to DOPA. DOPA will give rise to dopamine. Dopamine is put into the vesicle with the help of vesicular monoamine transporter, and that will convert dopamine. Dopamine will become noradrenaline with the help of hydroxylase. So whenever the action potential comes, sodium enters, calcium enters, the vesicle will fuse with the preselective membrane and release noradrenaline, which will act on alpha and beta. The termination of noradrenaline action is by uptake. Sometimes when it is uptaken back, it is metabolized by MAO, or it is put again into the vesicle with the help of VMAT2. Some of the noradrenaline can leak out and get metabolized by COMT enzyme. But this is not a major metabolism. The major metabolism is only seen when you give noradrenaline through IV. So when you give it to IV, then the major termination is by enzymes. But in synapse, the major termination is by uptake. Now, among all this, they can ask in the exam, what is the rate limiting step? The rate limiting step is by the enzyme tyrosine hydroxylase. What do you mean by rate limiting step? The whole process depends on this step. If this is slower, the synthesis of noradrenaline is decreased. Now there is a tumor. There is a tumor of adrenal gland, and there is excess secretion of noradrenaline and adrenaline. What is that tumor called as? Pheochromocytoma. In pheochromocytoma, the body synthesizes more and more adrenaline and noradrenaline. So how do you stop the production? By inhibiting the enzyme tyrosine hydroxylase. So the drug which inhibits this enzyme is called me-tyrosine. The enzyme name is me-tyrosine. So where do you use it? You have to use it in the treatment of pheochromocytoma. Sir, why should we use it? Now, pheochromocytoma is a tumor of adrenal gland where there is secretion of excessive adrenaline and noradrenaline. And to synthesize noradrenaline, you require the same steps. From noradrenaline, you get adrenaline. So if you block the rate limiting step, then you can stop the synthesis of adrenaline and noradrenaline. Then you can also inhibit an enzyme called decarboxylase. There is a drug called carbidopa. Carbidopa and benserazide. These two drugs are used in the treatment of a disease called Parkinson's disease. Parkinson's disease. So, the enzyme decarboxylase inhibitors like carbidopa and benserazide are used in the treatment of which condition? Parkinson's disease. We will discuss that in CNS down. Then you can also inhibit the enzyme vesicular monoamine transporter, and the name is called reserpine. The name is called reserpine. Now, reserpine was not used. It was used to treat hypertension. Now, you tell me what happens if I inhibit reserpine. If I inhibit reserpine, who will get depleted? The dopamine gets depleted because it is not put into the vesicle. The noradrenaline gets depleted. Why noradrenaline gets depleted? If you don't put the noradrenaline back into the vesicle, the MAO enzyme will metabolize this. So reserpine can deplete dopamine and noradrenaline without putting that into the vesicle, so the MAO enzyme will metabolize this. So you know that sympathetic system can increase the BP, and it was used to treat hypertension by decreasing the levels of norelin. But the problem is when the norelin level decreases in the brain, patient may have depression, and depression can lead to suicide. So one of the risk factor with the drug was suicide, and that's the reason why this was discontinued. The name is called reserpine. Now another important aspect is we have certain drugs called MAO inhibitors. So you can also inhibit the enzyme MAO. MAO inhibitors, if you inhibit MAO, the norelin is not metabolized. So they are used to treat depression. These are used in the treatment of depression. We'll discuss them later. Okay, so that's the reason why ANS is the most important basic thing to understand the various other systemic pharmacology. Very, very important. So the MAO inhibitors can be used in the treatment of depression. If you inhibit MAO, the norelin is not metabolized, the level increases. Okay, fine. Now the next important thing is you can also inhibit uptake of norelin back. So the drug which inhibit that, its name is called cocaine. Cocaine is the one which is going to inhibit uptake. Then we have tricyclic antidepressant. Again, these are used in depression. Then we have SNRI. So SNRI stands for serotonin norelin reuptake inhibitors, and these two are used to treat depression. And cocaine is an abusive drug. Why it is abused? The reason is simple, because when the sympathetic gets activated, person will not feel angry. He will be always attentive, alert. He wants to party. So that's why it's the drug of abuse. And remember, these three drugs are indirectly increasing the level of norelin. Yes. So we understood these things. The rate limiting step is blocked by me-tyrosine. The name itself is telling you me-tyrosine. Decarboxylase inhibitors are carbidopa benzerazide. They are used in a CNS condition called Parkinson disease. Reserpine was used for hypertension, but it depleted norelin, so risk of suicide increased, and it is banned now. The MAO inhibitors are used in depression, and cocaine, TCAs, SNRIs, they are also going to inhibit the norelin uptake by blocking norelin transporter. Clear, sir? Okay. Now another group of drugs are there. What do? These drugs will not allow the release of norelin. So they inhibit norelin release from the presynaptic terminal. What is that drug name? The drugs which inhibit the release, they are called as bretylium, and one more is called guanethidine. It is called bretylium and guanethidine. They don't allow the release of norelin from presynaptic terminal. Very, very important point. And this is your physiology. Then comes the pharmacology, and all this I am going to discuss to you later. Okay, so all these things we are going to discuss with you later. Yes. So once we understand neurotransmission, I just want to add one more point here. So this is the presynaptic terminal. This is the postsynaptic terminal. This is the presynaptic and postsynaptic. Now here what happens, there is something called a drug by the name tyramine. So we have tyramine and another drug called amphetamine. Tyramine and amphetamine. Now what happens here? The norelin is stored in the vesicle. When we use these drugs, tyramine and amphetamine, they enter inside and they displace norelin, and that get released, and that acts on the receptors alpha and beta. So tyramine and amphetamine, they are not directly acting on alpha and beta. You know that a drug doesn't acting directly on the receptor. They are also called as indirect. These are called indirect sympathomimetics. Indirect sympathomimetics. So one more drug which is an indirect sympathomimetic is the one which blocks the uptake of norelin. What is that? Cocaine. So cocaine is also indirect sympathomimetic. Others like TCAs, SNRIs, they are also indirect sympathomimetics. So remember, if I tell indirect sympathomimetic, what do you understand by that? They don't directly act on the receptor. They increase the activity of norelin, which acts on alpha and beta. The same concept we have discussed in parasympathetic, that is colon system. So this is what I had to tell you, and let us proceed to understand the receptors. So in the receptors, I told you we have alpha 1, alpha 2, beta 1, beta 2, beta 3, then D1 and D2. So whenever you get this question, you should tell me which type of receptors are these receptors. Are they ion channel or the GPCR or the nuclear receptors? Again, let us correlate with general formula. These receptors are mainly G protein couple receptor. But in that, are they GI, GS? What is that? There is a mnemonic called QI. In between, you write all the SSS, whatever you require. And the last one is I. So the alpha 1 is GQ, alpha 2 is GI, all the beta is GS couple receptor, and D1 is S, and D2 is I type of receptor. So what do you mean by alpha 1? It's a GQ couple receptor. It acts through the second messenger IP3DAG. So you know that IP3DAG are going to release calcium and cause contraction. So alpha usually is going to cause contraction. Now this alpha 2 is GI couple receptor and it decreases cyclic AMP. So it is inhibitory in nature, alpha 2. Beta 1 is GS couple receptor which increases cyclic AMP. So it is stimulatory. So write all the three. Again D1 is GS, it also acts by increasing cyclic AMP, and D2 is GI, it acts by decreasing cyclic AMP. So this is our correlation with general pharmacology. So the mnemonic is KISSI, alpha 1, alpha 2, beta, all beta are GS, D1 and D2. But mainly for your exams, you should be knowing the importance of the alpha and beta receptor. Now D1 is mainly in CVS and D2 is mainly in CNS. So D1 is in CVS, D2 is on CNS. So whatever we discuss, the CVS drugs is on D1, CNS drugs will be on D2. So let me clarify this. So DN1 is mainly we discuss in CVS, D2 drugs are mainly important in CNS. Okay, keep that point in your mind. Okay, so once we know the neurotransmission, let us understand the receptor location and what is their actions. So first receptor what I am going to discuss is a receptor called alpha receptors. In alpha receptor we have two types, the alpha 1 and alpha 2. We have alpha 1 and alpha 2. Now alpha 1, where is it located and what type of receptor is it? It's a GQ couple receptor. That means it releases IP3DAG and contraction. So what is the location of it? It is present in the eye. So what does it do in the eye? In the eye there is a muscle called dilator pupillae. So dilator pupillae is the radial muscles of the eyes, that is iris. In the dilator pupillae it causes mydriasis and we call it as active mydriasis. Active mydriasis. So the drug alpha 1 agonist will cause active mydriasis. So where do you want to dilate somebody's pupil? When you want to do fundoscopic examination or retinoscopic examination, there we do that. Now in the eye it is also present in ciliary blood vessels. Now what does it do? It's a contractor of blood vessel. So here it causes vasoconstriction and it decreases aqueous humor. It decreases aqueous humor production. Now tell me which condition you want to decrease aqueous humor production? Glaucoma. So these drugs can be used in mydriasis as well as glaucoma. Very good. So once we know the action on the eye, let us move on to another important action is on the blood vessel. Blood vessel. Now let me draw the blood vessel. This is the blood vessel. And in the blood vessel, we have mainly, the blood vessels are mainly controlled by alpha 1. Majority of the receptor is alpha 1. Some are alpha 2. But remember, minor are beta 2. So the tone on the blood vessel is always sympathetic. That's why the BP is always maintained. The sympathetic tone is always there. So that's why the BP is maintained. So remember this mnemonic A, B, C, D. A for alpha, whether it is alpha 1 or alpha 2, it is vasoconstriction. B for dilation. So alpha causes vasoconstriction, beta 2 causes vasodilation. So alpha means alpha 1 as well as alpha 2, they are known to produce vasoconstriction, but the major action is on alpha 1. So what happens when you do vasoconstriction? The total peripheral resistance increases, so that will increase the BP. So these drugs which stimulate the receptor, mainly alpha 1, they are used to treat hypertension. Beta 2 causes vasodilation, decreases total peripheral resistance, and it can decrease BP. But clinically, this is not so much significant. Otherwise, we would have used beta 2 agonist to treat hypertension condition. So beta 2, that's the reason I told you, they are not so much present in our body. I mean, in the blood vessels. So majorly, it is controlled by alpha 1. But what is the role of beta 2? Why the nature has given this beta 2? Imagine that you are running 100-meter race, or you are in some emergency. Suppose you are running 100-meter race. You tell me whether the blood vessels will constrict or dilate. Yes, if you are thinking it is constricted, I will give an example. Suppose you are running 100-meter race and your blood vessels of heart constrict, coronaries constrict. What happens? You will get a chest pain. If your muscles blood flow decreases, you cannot run. If the blood supplying the liver decreases, what happens? You will not get glucose. So in emergency, this comes to the action, and it causes vasodilation in cardiac, skeletal muscles, and in liver. It causes vasodilation. So in emergency, when you are running 100-meter race, there you require vasodilation, and in periphery there will be vasoconstriction. So that is the beauty of nature, to adjust to the situation in emergencies. Okay, so we understood the eye, blood vessel, and importantly, these are also located in the bladder. So there is something called the trigone of bladder, as well as in male prostate. So what happens here? This is the detrusor muscle, and this is the urethra. This is the prostate. This is the prostate. So the sphincters are controlled by alpha 1, and the trigone of bladder is also controlled by alpha 1. So when the alpha 1 constrict, the urine will not come. So it will cause contraction of sphincters, and there will be urine retention. There is urine retention. Not only that, this bladder has a receptor called beta 2 as well as beta 3. They are present in the muscle called detrusor. So what do they do with detrusor? You know, beta 1 and beta 2 or beta 3, they're all GS coupled receptors, so they can cause smooth muscle relaxation. So the detrusor relaxes. So again, that will also contribute to urine retention. So remember, the role of sympathetic is to retain urine. It is to retain urine. Remember, alpha causes constriction of sphincters. So that is about the bladder case. So once we know the bladder, let us understand one more important aspect. The seminal vesicles. The seminal vesicles, vas deferens. These are also supplied by alpha 1, and that is responsible for ejaculation. You know that sympathetic causes ejaculation. So these are the major actions you have to keep in your mind. Number 1, eye mydriasis, decrease aqueous humor production. Number 2, blood vessel vasoconstriction mainly. Beta 2 causes vasodilation, and bladder urine retention, and number 4, ejaculation. These are the major actions of alpha 1. So once we know the actions of alpha 1, let us understand the actions of alpha 2. Now what is alpha 2? It's an inhibitor GI coupled receptor. Okay, alpha 2 is a GI coupled receptor. Now it is located in 2 places. One is presynaptic, particularly in the brain, and in certain places it is also present postsynaptic. Sir, where is it presynaptic? As the name suggests, inhibitory. Let me write the presynaptic terminal. This is the presynaptic terminal, this one, and this is the postsynaptic terminal. right? Now here the receptor alpha 2 is present. Now what is the role of alpha 2? Is to decrease the release of noradrenaline. The role of alpha 2 is to decrease noradrenaline release. So it's like a brake, it controls the noradrenaline release. So that is the meaning of presynaptic alpha 2. Now presynaptically we have one more receptor called beta 1. So if alpha 1 can decrease the release, but beta 1 can increase noradrenaline release. So these are the control switches given by the nature for us. Why the nature has given? Suppose noradrenaline release is more, then alpha 2 will come to the picture. If noradrenaline is not released, then beta 1 come to the picture. So they are balancing this. So that is the meaning of presynaptic receptor. But postsynaptically it is not major, but some places it is also present in blood vessel. I told you it can cause vasoconstriction, but mainly in blood vessel it is alpha 1. Then it is also present in certain other organs. What is that? It is also present in pancreas. What does it do in pancreas? It decreases insulin release. It decreases insulin release. Sir, is it good or bad? Yes, it is good only. Why? When you are running a 100-meter race, you want glucose. So glucose should be more. So that is done by decreasing insulin release. So sympathetic causes hyperglycemia. Remember, sympathetic causes hyperglycemia. In the platelets, it has shown to increase aggregation of platelets. Platelet aggregation. And in the kidney, it has shown to decrease renin release. It has shown to decrease renin release. So I will correlate one thing here. Alpha to decrease renin release, but we have another thing called beta 1. Beta 1 increases renin release. So again we can correlate this. Whenever the sympathetic tone is high, then alpha 2 will come to the picture and decrease renin. When the BP is low, then the beta 1 will come to the picture and increase renin release. So the renin is modulated with the help of the beta 1 and alpha 2. Very, very important. Now it is also present in ciliary epithelium. Ciliary epithelium, that is in the eye. There it decreases cyclic AMP and decreases aqueous humor production. Aqueous humor production, where we can use them? We can use in the treatment of glaucoma. See, that's the reason. This very, very important. This sympathetic system, ANS, understanding that basics is very, very important for us. Okay, so that is about the location of alpha 2, which is mainly GI, but majority of the drugs what we use is they are going to affect presynaptic alpha 2, very minute effect on postsynaptic. Okay, so that is in detail. Now once we know the alpha, let us discuss the beta receptors now. Let us discuss the beta receptors. Beta receptor. Now beta receptors are G protein couple receptor, GPCR, and all are GS couple receptors. You all know that. Now there are three types of beta receptors: beta 1, beta 2, and beta 3. So let us understand one by one. What is the role of beta 1, beta 2, and beta 3? Let me tell you this. Beta 1, the major location of beta 1 is in the heart. In the heart, what does it do? In the heart, whenever you think of heart, think there is the nodal tissue as well as the cardiac muscle tissue. In the nodal tissue, when you stimulate beta 1, it increases the heart rate and it increases the conduction. So, can you tell me where these drugs can be used? Where do you want to increase heart rate? Bradycardia. Where do you want to increase conduction? You can use them in heart block. In muscle, they can increase force of contraction. So, where you want to increase the force of contraction, thereby increasing the cardiac output, obviously when there is cardiogenic shock as well as acute CHF. Now, in the heart, they can act on both atria and ventricle. Both atria and ventricle it can increase the force of contraction and also it can increase the heart rate and contraction. But you compare parasympathetic can only affect the contraction of the atria, but it cannot affect the contraction of ventricles. But here, beta 1 can affect the contraction of both the atria and ventricle. Now, once we are done with beta 1, the next important thing is the kidney. So, in the kidney, there are JG cells. Now, what happens whenever the BP falls? Whenever there is decrease in BP, there is decrease in renal blood flow, and that will activate, this stimulus will activate the beta receptor and GG cells, and these GG cells increase renin release. So the action of beta 1 is to cause renin release, so a regulator for that. So major locations are on heart and GG cells of kidney. Now another important aspect, it is also present in CNS. So what does it do in CNS? Yes, imagine that you are frightened by a snake. So what happens? Anxiety. So remember, sympathetic activation causes anxiety. Suppose you have exam tomorrow, anxiety. So this anxiety is what we call as performance anxiety. If you want to treat performance anxiety, you have to block this beta receptor, and the drug is propranolol. We'll discuss that later. So it causes anxiety. It can increase the attention. Sympathetic can increase attention. So which disease I can use these drugs? Attention deficit hyperactivity disorder, we can use these drugs. Another important, they increase alertness. So which condition you want to increase alertness? Where? Narcolepsy. Next, it can also cause anorexia. Now which disease you want to cause anorexia? Obesity, where the patient is eating more. So these are the uses, mainly to increase attention in ADHD, alertness in narcolepsy, anorexia and obesity. These are the uses of sympathetic drugs. We'll discuss them later. This is the concept you have to understand. Now I'll tell you one more correlation. When you are running 100-meter race, will you feel like eating suddenly? No. What about your alertness? Somebody is there to shoot you. You are alert, you are attentive, you are anxious. So this is about CNS. It is also present in ciliary epithelium. But in ciliary epithelium, it increases cyclic AMP and increases aqueous humor production. So we don't want more aqueous humor in glaucoma. So that's the reason we use beta blockers to treat glaucoma, right? So because when you stimulate ciliary epithelium, cyclic AMP increases and there is increased production of aqueous humor. So remember, mainly it is in the heart, kidney, CNS and ciliary epithelium where beta 1 is located. Mainly you have to remember the heart and kidney. Very, very important. Moving on to another important one, the beta 2. Now whenever we think of beta 2 is present in smooth muscle. Smooth muscle. Now let me correlate that with general pharma. Beta 2 will stimulate GS and GS will increase cyclic AMP, and that will cause smooth muscles to relax. So beta 2 is a smooth muscle relaxant. Same thing you correlate with beta 1. Beta 1 will also activate GS coupled receptor, and that will also increase cyclic AMP, but here it will be causing cardiac muscle contraction. Cardiac muscle contraction. So this is the contrary, you should understand. In the smooth muscles, it is relaxation. Beta 1, in the cardiac muscle, it is contraction. That is the contrary. Because beta 1 recruits calcium more and there is contraction. But beta 2 will inhibit myosin light chain kinase phosphorylation and it will not allow actin and myosin to combine, relaxation. So remember, beta 2 relaxation, beta 1 contraction. Very much important. So let me write again the beta 2 here. Beta 2 is a smooth muscle relaxant. So let me write what are the smooth muscles for you. Number 1, bronchus. What does it do? It's a bronchodilator. So imagine when you're running 100-meter race, obviously your broncho should dilate. You cannot wheeze and run. Second, in the blood vessel, it's a vasodilator. We have discussed the importance of that already. Number 3, intestine. It relaxes. Number 4, detrusor. Relaxes. So what happens is when you are running 100-meter race, we don't want the motility of intestine. We don't want the urine to come out. So the penultimate thing is urine retention and constipation. Right. So we understood bronchus, blood vessel, intestine, detrusor, and number 5, uterus. What do they do with uterus? Relax. Now, where do you want to relax the uterus? Which patient? There is a condition called preterm delivery. There we have to relax the uterus. So, beta 2 agonist can be used to relax the uterus. So, that is one location, smooth muscle. Apart from that, they are also present in liver. What do they do? In the liver, when you stimulate beta 2, they cause glycogenolysis. They cause glycogenolysis. So what happens? There is increase in glucose. So I told you sympathetic causes hyperglycemia. Beta 2 is also present in pancreas. Now what does it do in pancreas? Mild increase in insulin. Mild increase in insulin. You may ask a question, sir, why? Why should the insulin increase? Suppose you are running 100-meter race. You want glucose. The glucose is there, but you cannot utilize glucose unless there is some insulin. I told you alpha to decrease insulin, beta to increase insulin. With a moderate quantity of insulin, only the glucose can be used in emergency. Without insulin, glucose cannot be utilized. That's why there is mild release. But penultimate action is to cause hyperglycemia, and that is the role of sympathetic system. If you see the sympathetic system overall, that is responsible for hyperglycemia, that is diabetes. It is responsible for high BP, hypertension. So that's the reason why we should tell the patient to be in parasympathetic relaxed. If they are stressed out, they will get all this disease. That's the problem. So I told you the pancreas. Then coming to the skeletal muscles. Now skeletal muscles, the blood flow should be increased by beta 2. So beta 2 in the skeletal muscles increase the blood flow. And what happens if blood flow is increased? There is increase in exercising capacity. So person can do exercise very well because of the action of beta 2. Now skeletal muscles, if you stimulate beta 2 excessively, there is firing of muscle spindles. Muscle spindles will fire if you stimulate them excess, and the patient may develop tremors. So beta 2 can stimulate tremors, but it is also good for exercise capacity. It can cause hyperglycemia and relax everywhere. Now another important aspect, the beta 2 action is to cause hypokalemia. Beta 2 causes hypokalemia. Very, very important point recently asked in your exam. Now sympathetic drugs will push potassium into the cells. Suppose this is a blood vessel. This is the blood vessel. And this is the cell. So whenever we use beta 2 agonist, what do? If potassium is outside, they will push the potassium into the cells. So when they push the potassium into the cell, the potassium level comes down, and that's why they cause hypokalemia. They can cause hypokalemia. So recently they had asked a question. They had given an example of adrenaline. What is the role of adrenaline? Yes, adrenaline can cause hypokalemia because adrenaline can act on beta 2 and it can cause hypokalemia. So adrenaline or anything which stimulates beta 2, they can cause hypokalemia. Where do they push potassium into? They will push the potassium mainly into the liver and muscles. So they can cause hypokalemia. So the action of beta 2 is very, very important. If you know that, most of your other systemic pharmacology will become so much dead easier for you. That's why I'm taking time and making you understand. Please go through this. Beta 1 mainly in the heart, kidney, CNS. Ciliary epithelium, beta 1 can increase cyclic AMP and increase active silver production. And also the beta 2 is in smooth muscle, bronchus, blood vessel, intestine, detrusor and uterus. And one more location of beta 2 you can also write. Beta 2 is also present in the ciliary epithelium, and they can increase cyclic AMP and they can also increase aqueous humor. So that's why when we manage glaucoma, we have to block beta 2. So it is a bronchodilator, vasodilator. It relaxes the intestine, detrusor, and relaxes the uterus. Liver, it increases glycogenolysis, increases glucose. Pancreas, mild increase in insulin. Skeletal muscle, we require beta 2 for exercise capacity, but when you stimulate excessively, the tremors, and it can cause hyperkalemia, repeatedly asked question in your exams. Okay, that is about beta 2 in detail. Now moving on to the receptor beta 3. Beta 3 is present in adipose tissue. So in adipose tissue, it is mainly going to cause lipolysis and increase the free fatty acid levels. Now this is significant in brown adipose tissue, brown fat. So as the person becomes adult, the brown fat is not so much present. That's why beta 3 agonist, we are not successful in getting them for treating obesity, because they are mainly going to work on brown fat. And as the person grows up, the brown fat is lesser in the grown up person. So that's why many students ask me this question, sir, can we use beta 3 agonist and cause lipolysis and treat obesity? No, because the lipolysis is mainly in adipose, that is brown fat tissues. Now beta 3 is also present in detrusor, and since it is present in detrusor, it can relax the bladder. So these are the major actions of the receptors beta 1, beta 2, beta 3, alpha 1, alpha 2. So let me just revise these things. Location: alpha 1, alpha 2. Alpha 1 is present in blood vessel vasoconstriction, eye, mydriasis, then prostate, urine retention, and seminal vesicle ejaculation. And remember, wherever sphincter is there, it will cause contraction. Alpha 2 mainly, remember, it is presynaptic, so decreases normal release. Beta 1 mainly, you remember, heart and GG cells. And then beta 2 in smooth muscle relaxation everywhere, liver, glycogenolysis, more glucose. Muscles, you require the blood flow, then hypokalemia, and excessive beta 2 can cause tremors, and it can cause mild increase in insulin. Beta 3, adipose tissue, lipolysis leading to increase in free fatty acid, and also it can relax the detrusor. So that is the location and the actions of these receptors.